Hello everyone, this is Dr. Sangeeta Chaudhary and I welcome everybody to my channel today. So I am going to discuss about portal hypertension in today's class. What is portal hypertension actually? Portal hypertension is one of the important complications of liver cirrhosis. In my previous class, I have discussed about alcoholic liver disease and how it leads to liver cirrhosis. And I had mentioned that I'll be discussing about various complications of liver cirrhosis in my upcoming classes. So today here I am going to discuss about portal hypertension, which is an important complication of liver cirrhosis which we really need to know about, and we need to know how to manage a case of portal hypertension. So just to begin with the anatomy of portal venous system. Portal vein is formed by the confluence of splenic vein and the superior mesenteric vein. This is the splenic vein and this is the superior mesenteric vein. Okay, so the confluence forms the portal vein. This is the portal vein. Splenic vein also receives blood from the inferior mesenteric vein. So this is the inferior mesenteric vein. So basically, portal venous system receives blood from esophagus, stomach and intestines, okay, small and large intestine. So this portal vein, once it is formed by the confluence of splenic and superior mesenteric vein, okay, it will enter the liver. It will get divided into various branches, okay, and the small branches, ultimately they will drain into the hepatic sinusoids. Okay, it will get divided into branches and then ultimately it will drain into the hepatic sinusoids. These hepatic sinusoids are in turn will be drained by the hepatic vein. Okay, so these are the branches of hepatic vein, and these hepatic vein in turn it drains into the inferior vena cava. So this is the IVC. Okay, this is the IVC, inferior vena cava. Okay, so this is about the drainage system in the liver. Okay, portal venous system. So portal venous system, as just now we have seen, it carries blood from esophagus, stomach, small and large intestine, pancreas, gallbladder and spleen, and they carry it to the liver. Okay, portal vein is formed by the confluence of splenic vein and superior mesenteric vein, I have mentioned, and inferior mesenteric vein usually drains into the splenic vein. What is the length of the portal vein? The length of the portal vein is 7.5 cm approx, and it runs into the hilum of the liver. It gets divided into left and right portal venous branches, supplying the left and right sides of the liver respectively. Portal venules, they drain into the hepatic sinusoids. Just now I was mentioning, okay. So these hepatic sinusoids are in turn drained by the hepatic vein into the inferior vena cava. Okay, so this is about the anatomy of portal venous system. Portal venous blood circulation constitutes approximately 75% of total hepatic blood flow, and remaining 25% is derived from the hepatic artery, okay, which is the oxygenated blood directly from the aorta. So out of 100% of blood supply, 75% occurs via the portal venous blood circulation into the liver, and 25% is from the hepatic artery, which is the oxygenated blood from the aorta. So this is just a diagrammatic representation. Okay, this is liver, which receives venous blood, which receives blood from the portal vein. Okay, portal vein is formed by the confluence of splenic and superior mesenteric vein. Okay, so 75% of the hepatic blood flow is from the portal vein. The rest of the 25% of the blood flow is from the hepatic artery. Hepatic artery, it is the oxygenated, it carries the oxygen rich blood, okay, from the aorta, right? What is porta of liver? Porta of liver is the combination of hepatic duct, hepatic portal vein and hepatic artery. What does hepatic ducts do? Hepatic ducts, they carry bile from the liver, okay, into the small intestine, right? So hepatic duct, portal vein and hepatic artery, they form the porta hepatis or porta of liver. Now ultimately the blood from the liver will be drained by the hepatic veins into the inferior vena cava, and ultimately they will go to the right side of the heart. Okay, so this is about the blood circulation which is happening in the liver. Just look at the functional unit of liver. The functional unit of liver is a hexagonal lobule, okay, the periphery of which contains the portal triad. Okay, it is formed by the portal vein, hepatic artery and the bile duct. Okay, and the bile duct. So these three forms the portal triad. Okay, and then the in the center there is the central terminal venule which drains into the hepatic vein. Hepatic vein drains into the IVC. Okay, this is about the functional unit of liver, which is a hexagonal lobule containing the terminal venule at the center. Okay, and in the periphery there is portal tract. Okay, containing bile duct, portal vein and hepatic artery. Portal triads at periphery, as I have just now mentioned, it contains branch of hepatic artery, branch of portal vein and the bile duct. Okay, hepatic artery, portal vein and the bile duct. Now what is portal hypertension? Portal hypertension means when the portal venous pressure it is above 10 millimeter of mercury, that is portal hypertension, or hepatic venous pressure gradient more than 5 millimeter of mercury. So this is the definition of portal hypertension when you call as the person is having portal hypertension. Portal hypertension almost always results from increases in both portal resistance and portal flow. That means there pathophysiologically there can be two factors which results in portal hypertension. First one is resistance inside the liver for the blood flow, and second is the increased portal flow. Okay, so these two are the important underlying pathophysiological mechanism for portal hypertension. Pathogenesis. Okay, increased intrahepatic resistance to the passage of blood flow through the liver. As just now I was saying, increase in portal resistance. Okay, so increase in intrahepatic resistance which usually occurs in case of liver cirrhosis because of fibrosis inside the liver and regenerative nodule. Blood finds it difficult to flow through the increased resistance inside the liver. So there will be increased intrahepatic resistance. First factor. Second factor, increased splanchnic blood flow. Okay, splanchnic blood flow means blood flow which is going into the intestines and stomach, esophagus, pancreas and all those things. Why there will be increased blood flow in the splanchnic circulation? Because of secondary to vasodilatation within the splanchnic vascular bed. So these two are the very important mechanism underlying the portal hypertension. Okay, coming to the causes of portal hypertension. Causes can again be divided into various subgroups. They can be prehepatic causes, hepatic causes or post-hepatic causes. Okay, prehepatic causes can be thrombosis of the portal vein or thrombosis of the splenic vein. Prehepatic, as the name suggests, just before entering into the liver. Okay, or infrahepatic, below the liver. So thrombosis of portal vein or splenic vein will result in increased resistance to the blood flow, resulting in portal hypertension. Intrahepatic causes. Intrahepatic causes can again be divided anatomically into pre-sinusoidal, sinusoidal and post-sinusoidal causes. So among the pre-sinusoidal causes we have idiopathic portal hypertension, primary biliary cirrhosis, sarcoidosis, schistosomiasis. Okay, we need to remember the causes. Okay, sinusoidal causes, alcoholic cirrhosis, alcoholic hepatitis and cryptogenic cirrhosis. Post-sinusoidal causes, sinusoidal obstruction syndrome. If there is any cause of obstruction in the sinusoidal system, it will result in post-sinusoidal cause of increased portal resistance, means portal hypertension. Post-hepatic causes. Post-hepatic causes are very important. One of them is Budd-Chiari syndrome. What is Budd-Chiari syndrome? Budd-Chiari syndrome is thrombosis of the hepatic vein. Okay, so Budd-Chiari syndrome, constrictive pericarditis, obstruction of the inferior vena cava, right-sided heart failure and severe tricuspid regurgitation. So these are the 5 important causes of post-hepatic causes of portal hypertension. So this is how we divide the causes of portal hypertension into prehepatic, intrahepatic and posthepatic causes. Collateral circulation and varices. Okay, what is it? There are portosystemic anastomosis. That means anastomosis between the systemic vessels and the portal vessels. So whenever there is portal hypertension, this portosystemic anastomosis, okay, portosystemic anastomosis, okay, anastomosis. So this collaterals or portosystemic anastomosis gets open up in cases of portal hypertension, leading to shunting of blood from portal system to the systemic blood system. Okay, so portal pressure exceeds systemic venous pressure, so blood from portal system will directly go into the systemic venous system, bypassing the liver. What are the sites of collateral formation or portosystemic anastomotic site? They are the lower end of the rectum, gastroesophageal junction, retroperitoneum and umbilicus. So these are the sites for the collateral formation or for the formation of portosystemic anastomosis. Okay. Coming to the important part, there is the clinical feature of portal hypertension. So what are the clinical features of portal hypertension the patient will present with? First of all, we need to take a proper history and symptoms related to the etiology of the patient's presentation. We need to take about any history of variceal bleed. Variceal bleed, it is one of the complications of portal hypertension. So patient may present with features of portal hypertension or complications of portal hypertension. Stigmata of liver cell failure. Portal hypertension is a complication of liver cirrhosis, so there will be stigmata of liver cell failure. Fetor hepaticus. What is fetor hepaticus? It is a musty odor of breath resulting from portosystemic shunting of blood that allows mercaptans. Mercaptans, they are usually, they are, they are detoxified when the blood passes through the liver. But because of portosystemic anastomosis or shunting of blood, the blood will not go into the liver, it will bypass the liver, it will directly go into the systemic venous system. So mercaptans will go directly into the systemic venous system and they will directly pass to the lungs, through the lungs. So there will be fetor hepaticus or musty odor in the breath. Caput medusa. What is caput medusa? It's a number of prominent collateral vessels radiating from the umbilicus. As we know that umbilicus is one of the site of portosystemic anastomosis. So dilatation of this collaterals will result in caput medusa. There is something known as Creuvelia-Baumgarten syndrome. So what is it? Creuvelia-Baumgarten syndrome. It is the loud venous hum at the umbilicus. Okay, dilated abdominal wall veins will lead to a loud venous hum at the umbilicus, which is known as the Creuvelia-Baumgarten syndrome. And then splenomegaly. So these are the clinical features what we should really be keeping in mind about the portal hypertension. Okay, so again I am saying complication of portal hypertension like variceal bleed, then stigmata of liver cell failure, fetor hepaticus, then there will be caput medusa, Creuvelia-Baumgarten syndrome, splenomegaly. So these are important. There will be ascites as well in cases of portal hypertension. Okay. Now coming to the complications of portal hypertension, I will not go into the details of the complications of portal hypertension because I am going to discuss it in upcoming classes. Okay, so complications could be variceal bleed, hepatic encephalopathy, ascites, congestive gastropathy and hypersplenism. Okay, so these are the some very important complications of portal hypertension which should really be taken care of. Okay, otherwise they becomes life threatening. Investigations of portal hypertension case, we will do an LFT to find out if there is any features of hepatic failure, upper GI endoscopy to find out if there is any varices or any variceal bleed, ultrasonography of the abdomen, CT or MRI of abdomen. It will give us the idea about the size of the portal vein. It will give us the idea about splenomegaly, hepatic cirrhosis. It will give us the idea about ascites. So many ideas we can get from an ultrasonography or CT or MRI of abdomen. Portal venography important, wedged hepatic venous pressure. Okay, this should be wedged hepatic venous pressure. So these are the things we will do to find out if the patient is having portal hypertension or the complications of portal hypertension or not. Portal venous pressure measurement is done by wedged hepatic venous pressure. Just now I have mentioned. So just remember that WHVP or wedged hepatic venous pressure will give us the idea about the portal venous pressure. Coming to the treatment of portal hypertension. So how do we treat a case of portal hypertension? Our aim should be to reduce the resistance inside the liver for the blood flow, and also to reduce the amount of blood, or to reduce the increased blood flow through the liver. So non-selective beta blockers are of very much use, like propranolol, nadolol, carvedilol. They causes planning vasoconstriction, reduces cardiac output. So in turn they reduces portal flow. Okay, so non-selective beta blockers will reduce the planning vasodilatation. They'll cause planning vasoconstriction and reduction in cardiac output, which ultimately will lead to reduction in portal blood flow. Okay, nitrates, they reduces portal blood flow by reducing mean arterial pressure. Nitrates can also be used for the reduction of portal blood flow. Treatment of underlying cause is very important. I have talked about various causes of portal hypertension. So all the causes of portal hypertension should be sought for and it should be treated. And treatment of complication. I have named the complications. Now we need to find out if the patient has already developed complications of portal hypertension or not, and we need to treat the complications of portal hypertension. So if I talk about medications for portal hypertension, okay, most importantly two groups, non-selective beta blockers and nitrates, we use for the medical management of portal hypertension. Okay, so this is all about portal hypertension which I wanted to discuss today. Thank you so much for your appreciation and thank you so much for attending the class. Okay, in my upcoming classes I will discuss about other complications of liver cirrhosis and complications in management of portal hypertension as well. Thank you so much for attending the class.